Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. Hello, and welcome to a very special episode of the Sleep is My Waking Passion podcast. I am your host, Dr. Alison Kole, and I'm joined today by an old friend. This is Dr. David Fieno. He is an MD, PhD. He and I trained at Cedars-Sinai doing our residency and our fellowships. I went and veered into the pulmonary critical care and sleep arena, and David actually became a full-fledged cardiologist and then found an opportunity in Alabama where he is doing all sorts of amazing things. What's special about David is he's actually what you call a surgical cardiologist. And what he was sharing with me is this is very new. There's not too many people out there that would call themselves surgical cardiologists, but he really is an expertise not only in critical care, just like me, but he also does a lot of vein procedures, pacemakers, defibrillators, all sorts of neat little things that are really important for heart health. He also has experience treating heart failure patients, as well as having an obesity, essentially, I don't know if I'd call it a clinic, or you have a program, you have an obesity program. And I wanted to bring him here because I've been really interested in the relationship between heart health and sleep in general. And we know things like poor sleep quality, we know chronic sleep deprivation, which is an epidemic in this country, all contribute to essentially increased cardiovascular risk. It's bad for your heart, in essence, right? And once these medications started coming out where people are losing weight, and now we have some indication that this actually, I'm waiting with bated breath for these studies to be published and for more literature to actually come out. But it's very possible that we may have a new treatment for a incredibly common sleep disorder, which is obstructive sleep apnea. And I know that there's a lot of literature too that supports it for cardiovascular health. So I was like, Dave, can we talk about this? And he's like, yes. And, you know, a lot of people have a lot of schools of thought on this, and I really wanted to hear your perspective, David. It's been so wonderful to catch up on with you. I wanted to start, before we get into it, just with a couple of, let's get to the brass tacks of it all. Why do I specifically want to address GLP1 receptor agonist therapies that are out there? You know, your Wegovy's and your tirzepatides and all these medications that we're going to get into in a bit. One of the reasons is because with sleep apnea, there's literature for people who have heart failure, and now we're having this newer literature for obstructive sleep apnea. And what I want you folks to understand is that if you have sleep apnea, up to 20 to 60% of people with heart failure actually end up having obstructive sleep apnea. And when we talk about heart failure, a lot of people that I've had come to me say, oh, but the cardiologist told me that my heart is pumping strong. What do you mean I have heart failure? There's actually a couple types of heart failure. There is a weak heart muscle, what we call systolic heart failure. The ejection fraction goes down, how much blood comes out of the heart decreases. But actually, we have an epidemic of obesity, and it turns out that obesity actually causes our heart, even if it's pumping strongly, you can have heart failure despite having what we call a preserved ejection fraction. The heart appears to be pumping strongly, yet we still have those heart failure symptoms. And there's a lot of complicated reasons why that happens, but there you cannot talk about sleep apnea or sleep disorders like this without mentioning heart failure. So, David, welcome, because this is your area of expertise, and I'm just so thrilled to be able to, connect with you on this issue.
Alison, it's been too long since we've spoken, and I'm honored that you'd invite me to talk about this, that it's so close to my heart, and I have a hard time even knowing where to get started because we're on the frontier of something really great. What I love about what you just said is I love the idea that we're not doing two separate things, that you and I have one shared goal, and that is to help our patients. So it doesn't matter if you're an internist, it doesn't matter if you're a cardiologist, it doesn't matter if you're pulmonary and sleep specialists, that we all have one goal, and that is to help our patients. And maybe in this episode we can talk about where some of these drugs fit and what my experience has been so far.
That I would love that. Would you mind just explaining? A lot of people are reading this stuff and they're like, what is this? Like, how do these things work? How do they cause weight loss? Can we get down to maybe some of the basics? Like, what we know about these drugs is, I think, teaching us that we're interconnected, that it's not just one organ and then another organ and they're all separate, because these drugs are really working at multiple organs all at the same time. Can you share and explain that a little bit to our listeners?
Absolutely. And it's any one of these questions could be an hour-long symposium. And so I'm going to try to answer it correctly, but recognize that everything is not exhaustive. And unfortunately, neither you or I can provide specific medical advice to any one patient with this episode, but hopefully these will be some guidelines. I always talk about empowering my patients to know what I have learned so that they can make the best decision for themselves. And hopefully this is part of that empowerment. I was just at a conference. It was actually a heart failure conference in Florida. And interestingly, it was 70% nephrologists, 20% endocrinologists, 5% general practitioners, and 5% cardiologists. And what we all realized was that we were treating the same disease. The same drug that was helping the endocrinologists with their high blood glucose readings were helping the nephrologists with their kidney disease patients. They were helping the general docs to get their patients to lose weight and have a more favorable body habitus. And the cardiologist chimed in and said, oh, did I mention their heart failure is getting better? And no reason a group of lung doctors shouldn't have been there saying, I noticed their sleep parameters are improving as well. So what you realize is that all of us have a different name for the same disorder. So if you see the words preventive cardiology slowly start to get replaced with cardiometabolic improvement or cardiorenal metabolic improvement, and for you and I, cardiopulmonary improvement, that is an aphorism for we're all treating the same disease, and it's very possible that the same drug may be helpful for all of these things. So what we found probably now 7 years ago was that there were a group of what were traditionally considered diabetic drugs that, to put it mildly, we found had beneficial effects in non-diabetic patients, people who were traditionally considered non-diabetic patients. The reason that's important is we started using terms like pre-diabetes or borderline diabetes, and we later on have figured out, and by the end of 2024 can expect the terms pre-diabetes and borderline diabetes to actually be changed to early onset diabetes. That's exactly what this is. And what we found was that we were starting to have real improvements in these patients when we treated them, to the point where 7 years ago, one of these classes of drugs was not any longer a diabetic drug. And these drugs are called SGLT2 inhibitors, and they have a big, long mechanism of action that's in the tubule of the kidney, where it causes glucose to pool in the urine and therefore causes an osmotic diuresis in the patient. But to make a very long story short, we found that these drugs were useful in all heart failure patients, regardless of if the pump was dysfunctional, if the pump was normal, if it was a valve problem, if they had a rhythm problem, if they had right-sided heart failure, like what happens with sleep apnea. Didn't matter. They all got better. And the side effect profile, I'm not going to say it's impossible to have a side effect, but it was very favorable.
I just wanted to ask you about that because when we were chatting before, I was like, oh, I have some time to look it up. So, because these are not medications that I would commonly be other than sort of adjacent. I haven't typically prescribed them. I saw some concerns regarding, and I would imagine it might have to do with the diuretic effect and dehydration, but acute kidney injury, and then folks who had issues with perfusion and increased amputations. I was just curious about like the reality of that in clinics.
I'm so glad you're asking both those questions. So the first question, Allison, about SGLT2s and the risk of kidney injury. Of course, there's always a risk. I mean, let's you and I put it into perspective. We're both physicians, right? Peanut butter given to the wrong person can cause an anaphylactic shock and kill them. Vitamin C, the over-the-counter tablets that we might give in a patient who we thought was deficient or for immune health, given to the wrong person can kill them. There is no safe drug. Every drug has a risk to benefit ratio, and that's the essence of our job as internists, to try to give a patient which side of that risk to benefit that they fall on. With the SGLT2s, one of the concern was that the diuretic effect would harm the kidneys, and a cardiologist in previous years would be defined as a doctor that harms the kidneys for the nephrologist to come in and save the patient from dialysis.
I will say I'm chuckling just because
You
this
and I
is
remember
still
that.
an ongoing debate in the hospital.
Absolutely. You and I remember this working
Yes.
together in California. Well, the subsequent trial data, which we can allude to without boring everybody with graphs and Kaplan-Meier plots, showed in both DAPA CKD and in Emperor CKD that the exact opposite was true with these drugs, and that was that these drugs actually protected the kidneys.
Wow.
What you find in practice is that if you have a heart failure patient who you've got on high-dose diuretics, it's very reasonable to back off on those diuretics because they don't need them anymore, because now you have something to protect the kidney, right?
Interesting. Wow.
And then, if I can allude to the amputation rate, there was a drug that is in the SGLT2 class where there was a signal towards amputation prior when it was studied as a diabetic drug. So that's where this comes from. And you have to keep in mind, diabetics are among the most at-risk population for amputations of anybody in the world. And I think I told you when we talked before, I happened to be in our vein clinic today down here in Alabama, and I see big vein ulcers all the time. And I can assure you, these patients will get this class of drugs. And in my experience, with a reduction in swelling and interstitial pressure, circulation improves in these patients. Quite the opposite of that concern. So what I think that signal for amputation was, that they had an at-risk population that they treated with this drug, and unfortunately some of them were already predestined for amputation. And if that's the case, unfortunately with leg health, if you're already on that road, no drug or lack of drug is going to prevent that. And what we're finding in practice is that the exact opposite is true, is that these are most likely in the coming years going to be found to be protective for amputation. Now, that data is not out yet, but if you look at those same two trials that I mentioned, and you look at the placebo arm, a sugar pill, and the SGLT2, you'll see that the amputation rate is very comparable in the two groups, and it's actually quite low. Because these days we have ways to open those arteries and veins and prevent amputation, and many cardiologists do nothing but limb salvage. They try to save people's legs. So I digress. On to the second point. So about 2 years after the SGLT2s came on the scene, and my prediction, Allison, is that you will in the coming years be prescribing these for reasons we'll allude to. Another class of drugs and a brand name drug called Wegovy came out. And these are the GLP1 receptor agonists. And these drugs are a big group of drugs, actually, that first came out in 2007 and have an interesting history that we can maybe think about talking about as we go forward. But we started seeing remarkable reductions in body mass index, in body fat, in weight loss in patients who were refractory to everything else that they had tried: lifestyle, exercise, other medication therapies. Cut to today, about 20% of my patients have had gastric sleeve or gastric bypass surgery and come back 5 to 20 years after. And unfortunately, all the weight has come back. And
I see that so much. I agree. For going through such a significant surgery where, as a pulmonary critical care doctor, you see the flip side of the results of those surgeries. You know, folks getting bowel obstructions from adhesions. Like, you're doing an invasive procedure, and it feels, I can only imagine from the perspective of the patient, feels so frustrating. You had a surgery to manage your weight, and yet here you go, you're right back to where you were.
So what became clear within 6 months of prescribing this medication when I started was that we're onto something here. We're onto something really important. And the subsequent data, which is November of 2023, called the SELECT trial in cardiology, really showed beyond a shadow of a doubt what we knew to be true of the SGLT2s, which is that for at least one of the GLP1s, this is more accurately a cardiac drug that happens to be good if you're also diabetic. And so bringing it into mainstream, I think when we look at it that way, as we might look at traditional cardiac drugs, now we see a role for treatment in patients with heart failure. We see a role for treatment in patients who have blockages, what we call atherosclerotic vascular disease. And now we even have a role for prevention. We have a role for prevention of heart attacks, hospitalizations due to heart attacks, heart failure, and even cardiac-related death. And like the side effect concerns with the SGLT2s, the side effect profile is extremely favorable. It's not zero, but it's very favorable.
And now a quick break, but don't go anywhere. We'll be right back.
Struggling with sleep? Dr. Kole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, or wherever you get your favorite podcasts. The website has launched. So we have AskTheSleepMD.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website, sign up, and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well. When you are prescribed these medications, have you found that you don't need to go to the maximum dose? I have seen that just in the home here with one of my relatives. She's been doing very well with some weight loss, and she takes a very low dose and she's been fine. I mean, it's helped with all of her parameters. And I think the biggest help has been that she's been exercising and actually losing body fat. There may be a little bit of muscle loss that she's trying to combat with the exercise, but at the end of the day, I think it's the weight loss that's helped the most with her glycemic control and everything. But she really doesn't take a, quote, maximal dose of the medication that she's on. Have you found that different people need different doses and that it's okay for them to not max out? I think some people thinking they've got to go to the upper limits of what have you. And there's some people that may need that bigger dose. But in your experience, have you noticed any change in the dosing in terms of what you find works or doesn't work for folks?
Alison, you ask a great question, which is about the dosing of the GLP1 receptor agonists. And the answer is exactly what you just said. So first of all, every patient is going to be different. And as these patients get more svelte, as they lose the weight, first of all, the same dose is actually a higher dose for them because there's less of them. And if you've been doing this for more than 5 years, which I have, and your hair's all gray and your forehead's gotten all big, and you start to see a pattern, the pattern that you actually see is that as these patients get a different body habitus, their entire indication for this medication changes as well, and it's only fitting that the dosing would also change. Which leads me to how these drugs need to be correctly prescribed, which is you have to know what you're doing with drugs, period. You have to see your patients frequently. You have to assess them, and you have to make the modifications accordingly. And a team environment is probably the right way to do that. So, for example, every 1 to 2 months is extremely reasonable with the remarkable changes that are about to occur. Remarkably. Why? Because I have had to blow the dust off all my internal medicine knowledge and change all their drugs as they lose so much weight. In my own clinic, we have more than 25 patients who have lost over 200 pounds. And
wow.
I lost count after it got over 100 patients who had lost over 100 pounds. So the same dose of Synthroid that they've been on for 10 years is not the same dose anymore because their bodies have changed. Same thing with the GLP1 receptor agonists. Now, where this story gets extraordinarily interesting, 10% of my referrals today are from rheumatologists. Why would that be? I got a phone call from my dear friend, and he said, "Dave, what did you do to my patient?" And I said, "What are you talking about?" "I've treated this lady for 10 years for her lupus with biologics. You got her to lose 100 pounds. She's not only off of her biologics, but her lupus is gone. It's clinically gone. Her markers are now negative. What did you do?" And I explained what the program was. Now, I can't guarantee that kind of a result in everyone, but what we know from the autoimmune literature and what we know from our internal medicine days is that many of these diseases have several precipitating factors, and adipose tissue, body weight that's primarily fat weight, is full of inflammatory cytokines. It's full of inflammatory markers. And just rewinding a couple of years to our COVID experience, the obese patients were by far the ones who did more poorly with the condition than the ones who were not obese. And the hypothesis at the time was that the cytokines were multiplied by a high body mass index. As we get our patients to an ideal body weight, we reduce both the dosage and the frequency of these medications. And one of the things to really keep in mind is this medication has a long half-life. I didn't expect to be revealing this, but in my own journey of losing about 71 pounds, I lost 40 pounds on my own. And unfortunately, Alison, it's harder to lose weight when you get older. That took 2.5 years of strict dieting, twice a day workouts, good sleep. In years past, I could lose 40 pounds in 6 months if I really tried. It was 2.5 very hard years. Then I plateaued for 10 months, and I felt better, but I was not where I wanted to be. And that's when I finally started the GLP1. And today I feel like $1 million. But what's more important is I take one shot a month. This has a very long half-life, and it does extremely well in many patients dosed on a more frequent regimen, which has some relevance because these medications are hard to find right now.
And very expensive.
Very expensive. And the benefit is, in our preliminary randomized trials, as well as our experience, probably going to shape what you and I do in medicine in the next 10 to 20 years. So I know that's a bold statement to make, but there really needs to be some awareness of this. And what I heard 30 years ago was that a new technology called the internet needed a father. It needed someone to shepherd what was going to happen next. And whether that happened or not, I think that's very true. And I think your statement on responsible prescribing and doing this in a way that's sustainable, I love that word, sustainable. We need to be extremely cautious proceeding forward because we know from previous obesity literature that yo-yo dieting is probably more dangerous than just being overweight. So if we can think of a way to work together and have a common goal towards patient care, that's what you and I got into this for.
Thank you for that, because we are 100% aligned. And one of the things I just wanted to add regarding yo-yo dieting is, yes, it's probably more dangerous, but one of the issues is that you're really mucking up your body's ability to lose weight, because every time you lose weight, you lose lean muscle tissue. And what happens with that is lean tissue actually works in your favor. It actually increases your metabolism. So then, we are all organisms that need to eat and be, and how do we get optimal nutrition and be able to maintain a good weight? So that was kind of segueing into my other question is regarding the program that you guys have. What other parameters besides the prescription of medications have you found have really been very successful in your patients? And we had talked before that you're having a very strong success right now. So what are the other things besides the medications that are really working and resonating with your patients?
It's a great question, Alison. So the question is, other than GLP1 receptor agonists, what does my program at Heart South encourage, and what do we actually require in order to be part of that program, which is my best first attempt at how modern cardiologists should manage patients' cardiometabolic risk, aka their weight program. The thing revolves around your first examination in history. So that patient needs to be seen by an MD or an allied practitioner who does a full exam. So that includes all their medical history and, importantly, things that they have done in the past to try to lose weight. So if they've been on fen-phen, we need to know that. If they've had success with other medications used off-label for weight loss, like Wellbutrin, we need to know that. And allergies, certainly. Really important is a history of type 1 diabetes, because these drugs at present are contraindicated with type 1 diabetes. And the person doing that and deciding to do this has to have some familiarity with endocrine disorders and stay up to date, shall we say, on those things. Then a really critical part of this is to find out, what have you done in the past to try to lose weight? Or maybe said more politely, do you want to lose weight? What has worked for you? What hasn't? And patients will list this very readily, as I have. I started dieting when I was 11 years old. I went to the library and got a copy of Dr. Atkins' Diet Revolution, read it cover to cover.
Of course you did, because you're a smarty pants at 11 reading all that.
Many patients will say they've read about the caveman diet, keto. Many patients like intermittent fasting. Many patients have tried carnivore. There are lots of fad diets, and it's been fun for me keeping my Los Angeles roots and doing some of these interviews online and giving my own opinions about these diets. Really, the next step with all this is structured diet programs. Many patients have tried Nutrisystem, Weight Watchers. They've gone vegan. There are some other less common structured programs. Many patients have tried exercising out the wazoo. So they sign up for F45, they sign up for boot camp, they hire a personal trainer. And you need to have some sensitivity to all of this, because many people have become hopeless. I personally had lost weight and gained it back so many times. I really didn't know if anything was ever going to get me to where I was, which was interesting because, 7 years ago, I started really seeing the value of these, but I somehow couldn't make that connection for myself, or I just didn't want to start a medication that was originally a diabetic medication. And the very first thing to do is to find out if they actually want to do this thing, because, as you pointed out, it's expensive. It's hard to find these medications. It requires a commitment. You have to be seen frequently. My nurse practitioner, the greatest nurse practitioner in the whole world, really gets onto these folks when they come off their diet program, when they think they can eat what they want, when they don't do enough water, when they don't do enough natural foods. And at the end of the day, every patient needs to understand the basics, which is that all of us are what we eat. We are going to have to get on this horse over and over and over until we stop falling off. And probably to some extent, we're going to have to accept that this road will not be a straight down trajectory, right? There's going to be times when we fail, and we got to get right back on the horse and do it again. After the medical history, after what they've done, after the other medical conditions that they have, with the whole history of diet drugs harming the heart that goes back 30 years, I insist that everybody have a complete cardiac evaluation. And so that includes an echocardiogram, a stress test, and often a vascular evaluation. That's baseline. And I do that baseline simultaneously with any medications and lifestyle interventions that I recommend. And my first step with my adult patients is I say, we're going to try these things, and you are going to eat 4 servings of fresh fruit and vegetables every day. Serving is the size of your fist. So 2 fruits, 2 vegetables, 4 vegetables, 4 fruits, whatever. Fresher the better. And then in general, you can go ahead and have what you want after that. Try to avoid the stuff that you know is not good for you, is what I say. But do that. And the second thing I tell these folks, you got to walk. You got to walk every day. Start with 5 minutes, but you have to walk every day. Alison, walking at an average rate, if you walk 5 minutes a day, how many marathons you think you walk in a year? Just guess.
Oh, God. 1? 5. Wow.
If you walk 10 minutes a day, every day, you walk 10 marathons a year. So these habits are what I'm after. I'm not after any short-term fix. If you take and go to the grocery store, my dear friend, and you look at a 4-pack of butter, that's 1 pound. And if I have this conversation with every patient. If you hold that up to your side and imagine that solid oil mass having in your body to get dissolved, turned into chylomicrons, go to the liver for processing, gluconeogenesis, then going to your lean muscles, your muscle mass, being burned and excreted. There is no way in heaven or hell that is going to get processed faster than a pound per week. Frankly, the safe way, it's going to be a pound every 2 to 3 weeks. And then I set a first goal with them. Let's say you want to lose 25 pounds. That's a great first goal. I look them right in the eye and I say, that's going to be 50 to 75 weeks the way we do this. We're going to do it slow, and the slower, the better. The more likely it is to stay off. My own journey, I mentioned, has been 4.5 years. I'm 2 years at the weight where I want to be. I've never been the right weight for more than a year in my whole life. So as we get into the sustainability of this thing, you have to see your patients frequently, because I've had to blow the dust off my eating disorder knowledge and pull these drugs off of some patients. And I've had to find out what is the real thing that's going on. That just came to my mind. One of my patients was not volunteering that he drank a 6 to 12 pack of beer every night before he went to sleep. Well, no wonder he was so sick. Those are broad brushstrokes, Alison, but it goes back to what we learned at Cedars-Sinai, which is that nothing takes the place of a good history and physical. And to quote the very first, who is said to be one of the first cardiologists, whose name is escaping me, but he invented the stethoscope, but he said the secret to the care of the patient is to actually care about the patient. So when you care about their struggle, you'll ultimately get to a point where they trust you and basically do what you say. And that's a great responsibility. And what you're getting at are their habits. And that's what you're trying to emphasize over the next year, what I would call the first year of the program.
Wow. I cannot even, Dave, this has been such an amazing conversation, seriously. Guys, I do talk about obstructive sleep apnea and how weight loss can impact obstructive sleep apnea with Dr. Audrey Wells. So I encourage you to check out that episode. In general, if you're going to lose weight, your sleep apnea, you do have fat pads in your tongue. There was actually a study by a gentleman named Dr. Wang who actually demonstrated in 67 patients that it was kind of the loss of fat tissue. They were not using these medications, but they were just on a weight loss journey, that if folks could lose weight, we see improvement in their obstructive sleep apnea. I want you to leave here not focused on that. Listen to Dr. Audrey Wells and I chat about it, because we've covered that. I want you to leave here feeling very empowered that what Dr. Fieno is telling you, what David's telling me, and our conversation has been really enlightening, because what you're seeing are doctors who may have decided to go different fields, different specialties, and have theoretically different interests, all with the same unifying factor of wanting our patients to be better, and knowing that here's your hypertension med, slap. Here's this, slap, right? It feels like a slap. But if we don't take a step back and say, we got to take the medications here, and we got to look at, I put a Band-Aid on a much bigger problem. And that is really ultimately where we're getting at. So, Dave, it's been so amazing to reconnect with you. I think you're doing such amazing work over in Alabama, and I'm just tickled that we get to have this conversation. I am hoping that I get to see you in person so I can give you a giant hug in June, if you're going to be there for that reunion.
I've already bought the plane ticket and have the reservation for the Sofitel, so I'll see you back home at Cedars, and I look forward to catching up more. And Alison, it's amazing to see what you've done, and we're awfully proud of you.
We have an amazing class. Oh my God, we're lucky. Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.